The Autism Research Institute relies on the generosity of donors like you to make this webcast possible. If you enjoy this presentation, please consider making a donation. Thank you.
Before we get started, I'd like to introduce our speaker. Dr. Lauren Moskowicz is an assistant professor of psychology at St. John's University. She received her BS from Cornell and her MA and PhD in clinical psychology from Stony Brook University. She completed her internship at NYU Child Study Center and Bellevue Hospital and her postdoctoral fellowship at NYU Child Study Center. Her research focuses on behavioral assessment and intervention for children with autism spectrum disorders and other developmental disabilities in naturalistic contexts, intervention for parents of children with ASD and DD, and cognitive behavioral therapy with children and adolescents. You can type your questions into the question section starting now and throughout the talk. We'll answer as many as possible at the end. These webinars are made possible through generous donor support. If you'd like to contribute, please visit our website at autism.com. And now I will turn it over to Dr. Moskowicz.
Hi, everybody. This is Lauren Moskowicz. Today I'm going to be talking about assessing and treating anxiety and problem behavior as it relates to anxiety in children and really individuals of all ages with autism spectrum disorder. Some of you may have seen the webinar I gave for ARI in June, a few months ago, and this is different from that because the focus of that was on treating challenging behavior or externalizing behavior, things like self-injury, aggression, tantrums, etc. We talked about doing a functional behavior assessment and then designing prevention, replacement, or response strategies based on the results of the FBA. And one thing I alluded to in that presentation was that one of the functions of problem behavior, for those of you, you might remember that there could be several functions or purposes of problem behavior or challenging behavior, like to gain attention or escape or avoid something you don't want to do, like homework, or to obtain something, an activity you want. But one of the possible functions of anxiety that we mentioned briefly was that individuals with autism may engage in problematic behaviors like aggression, self-injury, tantrums, etc., to escape something that makes them anxious. And they may not be able to talk about the fact that they're anxious. So given that there were, I think, a bunch of questions about that, we decided to do a full presentation on how you would assess and treat anxiety and problem behavior as it relates to anxiety in individuals with ASD. So today our focus is on anxiety specifically. And, keep in mind, like we said, a lot of times individuals are engaging in tantrums, self-injury, aggression, etc. And today we're going to talk about how to address those behaviors when the function of it is to escape or avoid something that makes you anxious. Okay? All right. So first, we'll start out, what is anxiety? People probably use the term all the time and say, oh, I'm so anxious. But, it actually has a very specific meaning or definition. So first, let's explain what that is. So anxiety actually has three components. Some would say four components. But the three main components are the behavioral component of anxiety, the actual crying or running away part, the physical feelings part, your heart pounding or sweating, or your subjective feelings of worry or dread. And then your thoughts, the thoughts you're thinking, like, oh, I'm going to fail the test, or the spider's going to bite me, or I'm going to die if I don't wash my hands, and the germs are going to kill me. Whatever the thoughts are, there's thoughts that also make up your anxiety. Okay, so those are the three main components of anxiety. In some more detail, so there's the feelings component of anxiety, like we said, which could be made up of all the feelings of physiological arousal that you have when you're anxious. And, there's the picture, I think, from Jurassic Park, because your body is wired to have those physical feelings when you're anxious, because it's adaptive in some way. Back in the day when, you were running from a lion or running from some sort of predator, you want your body to go into fight or flight mode so that you are running away from the lion, so your heart's beating fast, trying to pump blood to your extremities, to your feet and your hands so you could run away. So your heart's beating fast. As a result, you're having heavy or rapid breathing, your muscles are tense, your face might be flushed, you might be perspiring, you might feel nauseous. Think of all the different ways you feel when you're worried about something or when you're anxious, you know, when you're going to take a big test or something like that. You know, you might have butterflies in your stomach, you might feel like you can't catch your breath. Those feelings are all a part of anxiety, and that's, again, just one part of anxiety. Okay, and the feelings part of anxiety really also includes the sort of subjective feelings of anxiety, because, you know, your heart might be beating fast if you're running up the stairs too, but that's not the same thing as being anxious, right? So there is this kind of subjective feeling or affective component of anxiety. Then there are the thoughts that make up anxiety. So here, you know, you see I'm trying to minimize the thing on my screen to see it. So you see a little kid here thinking, oh, what if the spider crawls on me and then bites me and I die, right? You know, a lot of people might see a spider and not think that. They might think, ew, gross, or they might think, oh, it's cute, like in Charlotte's Web, or they might think nothing at all. But then some people, you know, when they see a spider, they might think, what if it crawls on me and bites me, right? So that's an anxious thought. And so thoughts or cognitions are also a part of anxiety. And there's a lot of type of, we call it cognitive distortions is the fancy word for it, or thinking traps is another term for it. There's a lot of kind of thinking traps that people fall into when they have anxiety that lead to anxiety or contribute to anxiety. One of those, for example, is catastrophizing, always thinking the worst thing ever is going to happen. So not just, you know, oh, the spider's gross, but the spider's going to bite me and then I'll get an infection and then I'll die. Or, you know, one example I always give, one of my teenagers I worked with once, for example, was afraid that if she failed her test in high school, then she was going to fail out of class and then fail out of high school and then never get into a college and then wind up never getting a job and then wind up becoming a stripper. So you can see that big kind of snowball, right? From not just, oh, I'm going to fail my test, but really just snowballing until you get to this horrible, horrible final outcome, right? So that's something that people do a lot when they're anxious. There's mind reading sometimes, believing what you think other people are thinking about you. So, you know, the example we always give is, you know, if you pass someone on the street, you know, and you said hi, someone you knew, and they didn't say hi to you, there's two different things, well, many different things you could think. But one thing you might think is, you know, oh, he didn't see me, right? Which would probably make you not really feel or think much of anything. You might forget about it. But someone with anxiety might think, someone who has some difficulties with anxiety might think, oh, he didn't say hi to me because he doesn't like me. Or because he's upset with me or because he's mad at me, right? And that's going to make you feel pretty anxious and worried, or possibly angry, I guess, depending on who you are, right? So the way you're thinking about a situation is really, really influencing how you feel and how you behave, right? If you're thinking, oh, he doesn't like me, he's mad at me, you might not say hi to him next time. Whereas if you're just thinking, oh, he didn't see me, you might say hi to him next time, right? So these things are linked, our thoughts, feelings, and behaviors. Back to that slide. Right, just like that slide here. Oh, we can't go backwards. But yeah, the slide where our thoughts, feelings, and behaviors are linked, that triangle slide. That's the important thing, that they all affect one another. So mind reading is another thing people do, thinking, oh, he's mad at me, or he doesn't like me, or he hates me, or he thinks I'm stupid, whatever it is. Fortune telling, predicting that you think something bad's going to happen in the future. All or nothing thinking, which we sometimes call black and white thinking. For example, believing if you don't do something 100% perfectly, you failed, or thinking, you know, either I get into this one college or that's it, I'm never going to be a success at all in my life. You know, just thinking things are either one or the other. Let's see, or oh, if so-and-so didn't talk to me in the hall, it means he hates me and I'm not his friend. You know, really kind of jumping to conclusions, not really seeing any middle ground or any shades of gray sometimes, you know, but really thinking things either have to be one way or the other. And then just in general, sort of negative thinking, really picking out only the negative aspects of the situation. You know, if one of my kids who sang in a play, for example, she was very worried because one time she missed one note or sang one note wrong. So, you know, things that other people might even notice, but you're really worried about or thinking about that one little negative thing that you think everyone's noticing, maybe like a pimple on your face, but no one else is probably thinking about that, right? So all those thoughts are really part of anxiety. Then there is, of course, how come it's not going to the next slide? Sorry. Oh, there we go. Then there's the behavioral component of anxiety, okay? And that is the part that that is most noticeable and that we most often talk about in applied behavior analysis, just the behavioral part of it. The classic escape or avoidance behaviors, such as running away, running out of the room, right? You know someone's afraid if, they run out of the room when they see a dog or a spider or maybe other people. Cowering, freezing can be another behavior. Reassurance seeking, that's pretty common with a lot of their kids. Did I do that okay? Did I sing that well? Did I sing that well? Did I play that well? One of my little kids with pretty severe OCD who had autism was always asking his mom for reassurance if he was sick. Am I sick? Am I coughing right? Am I breathing right? Does it look like I'm flushed? Those sorts of things. Asking parents or teachers, usually parents, for really constant reassurance to try to help relieve their anxiety. Pacing back and forth, crying, all these things could be behaviors that indicate anxiety. Okay, so those are the three main components of anxiety. Just moving this slide. Okay, so just now that we defined anxiety, we'll briefly address just some background on anxiety and autism spectrum disorders. So, back when I actually first started studying anxiety, I would say, whatever year that was, not too long ago, 2006, there was really nothing on it. There was very, very little, like a handful of studies that were on it. Especially in applied behavior analysis, there's really, really a reluctance to ever talk about the term anxiety. And I think a big reason for that is because in applied behavior analysis, there's really only a focus on behaviors. You don't want to, what ABA people call mentalize. You don't want to mentalize and say, oh, he's doing that because he's anxious, because it's really hard to prove the cognitive and physiological and feelings component of anxiety, right? When in ABA, you can only really talk about what you see right in front of you. And a kid might run away or cry or yell because of lots of things, because he doesn't like something, or because he's angry, or because he doesn't want to do his homework, not necessarily because he's anxious. So in ABA, or applied behavior analysis, it's really hard to kind of prove that anxiety component. We'll talk more about that. So I think that's, there's a reluctance among operant researchers to really talk about the construct of anxiety, pretty much. So that's one reason historically why there wasn't much on it. But really, in the past 10 years, 5-10 years, so much has come out. It tends to be more in those children with autism who are verbal and have a higher IQ, because it's even harder to measure anxiety in those kids who don't. But the studies that have come out have actually shown that, contrary to the belief that, individuals with autism couldn't experience anxiety or didn't have anxiety, anxiety is actually more prevalent in youth with autism spectrum disorder than in typically developing individuals, or even in those with other developmental disabilities, such as Down syndrome. It's more common in children with autism than all those groups. But like we said, anxiety is often overlooked or unrecognized or really underdiagnosed in individuals with ASD. Due to by behaviorists, behavior therapists, ABA practitioners, and psychologists and psychiatrists, often a lot of groups. And one main reason it could be overlooked or undiagnosed is because of how difficult it is to, like we said, assess or measure anxiety in individuals with autism. This is in part due to their communication deficits. Like we said, anxiety has those three components. So we can observe the behavioral component. We can observe an individual running out of the room or crying or yelling or cowering. But they could be engaging in those behaviors for a variety of reasons. If they can't talk and say, I'm anxious, or I'm afraid of that, or, this test is making me nervous, or I'm scared the spider's going to bite me. If they can't verbalize those thoughts, it's really hard to get at the cognitive components of anxiety, or even the feeling components, like my heart's beating really fast, or, I feel lightheaded, or I have butterflies in my stomach. If a kid can't tell you that, it can be really difficult to figure out that anxiety is what's going on, right? Because all you have is the behaviors to go on if an individual has an inability to communicate. This is, of course, an issue in individuals with autism who are nonverbal, but really it's even an issue for individuals with autism with a higher IQ, because they have what's called alexithymia, and that they may have difficulty, even those who are completely verbal with a high IQ, may have a lot of difficulty verbalizing their emotional states. So they might be able to tell you a lot about facts or other things, but they might have a lot of difficulty talking about, if they're anxious or afraid or frustrated or sad or happy. That's really kind of a part of autism, that difficulty talking about emotions. So the communication deficits are one reason it's so difficult to measure anxiety, because like we said, we can only really measure the behavioral component. It's much harder to figure out how to measure or assess the cognitive, affective, physiological sort of components of anxiety. And then another reason is the what we call idiosyncratic behavioral expression of anxiety in kids on the spectrum. Like we said, some of the behaviors that typically indicate anxiety are, kind of obvious, like running out of the room or crying. Those are fairly obvious. But then some individuals with autism really express their anxiety in a very odd or idiosyncratic way. Like one of my kids would always say, "Daddy, where's deodorant? Daddy, where's deodorant?" when he was anxious, right? So if you weren't his parents or didn't know him, you wouldn't really know that that meant he's anxious. So again, some kids might engage in, or one of my other kids would say, "Here we go, everybody," or "Come on, everybody." So sometimes they have specific phrases, stereotype sort of phrases they use, or specific body motions, or specific facial expressions. For one of my kids, it was plugging his ears, things they do that indicate they're anxious. So that's another reason it could be difficult to assess or measure in kids on the spectrum, because it may look a little bit different, the anxiety, than it does in other children, especially because sometimes their facial expressions are different than neurotypical children. So they might not express their anxiety in the way we're used to, right? Another reason anxiety is often overlooked or unrecognized could be due to what's called symptom overlap and unclear differential diagnosis. So, you take a symptom like social avoidance, a kid not saying hi to someone. Is that because he has social anxiety, or is that just part of the social avoidance that you would see in autism, right? Or if you see a kid opening and closing doors, is that checking a kind of ritual that you would see in OCD, obsessive compulsive disorder, or is it just one of the classic kind of stereotyped behaviors you would see in autism? It can be really, really difficult to tease those things apart, which is another reason it can be hard to diagnose in individuals on the spectrum. Related to that, there's also what we call diagnostic overshadowing, whereas classically the diagnosis of autism would sort of overshadow everything else about that kid. What do you mean they're anxious? That's just the autism. It's just the autism, And I think, again, that's the way it used to be, but we've really, come a long way from that in these past few years, where people really are recognizing, no, kids with autism can have anxiety, and they can have ADHD, and they do have all these temperamental variations that neurotypical kids have too. There's more to them than just the autism. They have, strengths and limitations that are completely separate from the autism. So again, but I think classically that was one reason it was difficult to diagnose in this population. So take-home message here. Anxiety actually is much more common in kids with autism than in other populations, but it's much harder to diagnose in kids with autism, so it's kind of that double whammy there. So that's some background. Sorry, I'm having difficulty clicking. Okay, so I don't have a lot of time to talk about assessing anxiety today, unfortunately, because we're going to just try to get to the treatment piece. But there are some assessment instruments. A lot of the ones that we use, a lot of the parent reports and parent interviews and child interviews and child questionnaires that we use in neurotypical kids don't necessarily translate as well for kids with autism. Often because parents will say things like, well, how do I know if they're scared, or how do I know if his heart's beating fast? So it can be really hard sometimes, the classic measures that people use. There are some studies, though, that have come out recently that show that some of the measures that have been used for neurotypical kids, or typically developing kids, can be used for children with autism spectrum disorder, those at least who have an average or above average IQ, not necessarily those with ID. For those of you who are interested in specific measures, you can contact me and I will let you know about those. But one thing I'll just briefly mention is a study we conducted a few years ago, published in 2013 in AJIDD. We really attempted to operationally define the construct of anxiety in 3 children with autism spectrum disorder who also had an intellectual disability, or ID. because, like I said, most of the research on assessment really looks at those kids with autism who have an average or above average IQ, not those who have an intellectual disability, what we would formerly call mental retardation, but is now referred to as intellectual disability. Anxiety is much harder, like we said, to diagnose in these kids, often because they can't talk or tell us what's going on. So in this study, we did really kind of try to assess those three components of anxiety. The feelings component, which we assessed with an affective contextual measure, where we assessed that with parent ratings and blind undergraduate ratings of how anxious the kids seemed. Then we assessed the idiosyncratic behaviors that indicated anxiety in each of the three children. Things, like I said, for one child, it was like plugging his ears or turning his head a specific way. For another child, it was specific phrases like "Don't leave, mommy." And actually, I'll tell you about what those behaviors were as we get to those specific kids. And then to assess the physiological arousal, the children actually wore a heart rate monitor, which showed increased levels of heart rate and decreased levels of what we call RSA, or your parasympathetic activity. So it's like they have too much accelerator, if you will, and maybe not enough putting on the brakes. So there's a lot of physiological arousal difficulties there too. So again, we were able to kind of show that, or try to document that these three children were experiencing anxiety in specific situations, which we'll talk about, and that there's a relationship between anxiety and problem behavior, in that fewer problem behaviors, whether that's aggression or tantrums or yelling, occurred in the low anxiety than in the high anxiety conditions. And this sort of supports the hypothesis I mentioned at the very beginning of this talk, that one of the reasons, classically, like we said, applied behavior analysts would say individuals engaged in problem behavior or displayed problem behavior to escape a demand, something they don't want to do, or to gain attention, or to gain a tangible item or activity, or for sensory stimulation. But really, our hypothesis is that individuals with autism also may engage in problem behavior to escape or reduce anxiety. So this study really kind of supported that hypothesis, at least in these three participants. So the study dealt with how to assess anxiety in these participants, and then we also developed an intervention to address the anxiety, which is what we'll spend the last part of this presentation talking about today. But before we get into how to treat anxiety in children with autism, I thought it was important to try to really give a brief overview of how we treat anxiety in neurotypical children, those, again, who don't have autism or a developmental disability. And then I can explain to you how we modify it, or how it's a little bit different for those who have autism, okay? So one of the main components of treating anxiety in individuals without autism, and this is actually both children and adults, is what we call psychoeducation, which is just a real fancy schmancy psychology word for educating people or providing them with information about anxiety. So we explain what anxiety is, just like I defined it for you guys today. We try to normalize anxiety, which means just explain that everybody has some anxiety, right? Everybody in the world has some anxiety and has a function or purpose. Like we said, it's adaptive. If you didn't have any anxiety, you wouldn't be able to escape a predator, right? Nothing would mobilize you to escape a predator. Or you wouldn't probably even be motivated to study for a test or really do anything if you didn't have any anxiety at all, right? Because anxiety mobilizes us to action. So there's some good things about it. Everyone has anxiety. The problem comes when we have too much anxiety, right? Too much, and it's interfering with our ability to really get things done or function. And that I should mention at the beginning when I talked about those three components of anxiety. So everyone has it, but we really only diagnose an anxiety disorder if there is clinical impairment, meaning if it's really, really interfering in someone's life. So for example, I'm afraid of spiders. I don't like them. But it's not an actual diagnosable phobia because it's not impacting my life in any way. Whereas one of my girls with autism, who I worked with, was so afraid of spiders that she actually wouldn't go to the bathroom in school. She was 9 years old because she was afraid that there might be spiders in the bathroom. So she would actually have accidents in class because she was so afraid to go to the bathroom that there might be spiders. That is a clinical level of impairment, right? So again, normalizing anxiety. We all have anxiety. It has a function or a purpose. There's a reason for it. But The problem comes when we have too much anxiety or when our fight or flight systems are going off in a situation in which there's no danger. And that's really what an anxiety disorder is. Our body's telling us that we gotta escape the predator, run away, we're mobilizing, we're sweating, our heart's pounding, but there's really nothing to be afraid of. It's kind of a false alarm. Okay, the fire alarm's going off when there's just burnt toast, but there's no actual fire. All right. So these are all the things we explain to individuals, both with or without autism. And we also try to externalize anxiety, right? Because again, people might feel a lot of blame, like it's your fault, but really, anxiety is just a problem like anything else, just like if you have a headache or a cold or anything else. And it's much easier to fight the anxiety if you can see it as something separate than you. So with individuals, with adults, we will just call it your anxiety or your OCD. With kids, we often have them name their anxiety. It can be, for one of my kids, it was Voldemort, for example, from Harry Potter. Because then, you're fighting Voldemort. You're really helping your child in fighting Voldemort versus, feeling like you're against your child. It's really you and your child are on the same team against his anxiety. So one thing we really try to do is externalize anxiety, okay? What else? And, that way you can say, too, this is just my OCD talking. This isn't me. You're just junk mail, OCD. You're not real. Stop bossing me around, whatever it happens to be. This is just my anxiety talking. I don't have to listen to it. I don't have to pay attention to it. So, again, it really, really helps to externalize your anxiety. And we explain the rationale for treatment. We explain the rationale for why we're doing exposures, which we'll talk about, I think, in the next slide, and how you'll eventually habituate the more you expose yourself to something that makes you anxious. So we explain all of this in what's called psychoeducation, because, again, it makes it a lot easier to address anxiety if you can really explain to people what it is, what the point of it is, and how you go about addressing it. Okay. Next slide. Okay, so I would argue the main element of treatment in confronting anxiety disorders is what we call graduated exposure. And what that is it's what it sounds like, is that you're gradually exposing the individual to an increasing proximity or intensity or amount of the feared stimulus or situation. Increasing proximity meaning you're getting closer and closer to something that makes you anxious, like a spider, or increasing intensity of something, like if it's thunder, you might be listening to it louder and louder and louder, or amount of the feared stimulus. So if it's a social situation, you might start out at a minute and then go into 5 minutes or 10 minutes. You're basically, think about it as going into the shallow end and eventually progressing to the deep end of the swimming pool. And think about it. And the whole point of graduate exposures is eventually you're going to habituate, which means you're going to get used to it. When you first jump in a cold pool, it feels really cold, right? But it doesn't feel cold after you've been in it for a minute or 5 minutes, maybe not even after 30 seconds, because your body gets used to it. So, when people hear, wait a minute, I'm coming to see you and you're just going to tell me to do what makes me afraid of? If I could just do what makes me afraid of, why would I be coming to see you, right? So it kind of seems like, well, duh, or a no-brainer in some ways. But the important thing to remember is what actually maintains anxiety is avoidance. If you are afraid of dogs, when you see a dog, when you're crossing the street, you see a dog walking down the street, the natural instinct is to walk to the other side of the street, right? Escape the dog. And when you do that, you get reinforced in the moment. Your anxiety immediately goes down. Your heart rate immediately goes down. You immediately feel better, right? So what you learn is the next time I see a dog, I should walk to the other side of the street again, right? So that works in the moment. You feel better in the moment. But the problem is you never get to actually see that nothing would have happened to you if you confronted this dog. Or that if you stay in the situation, your anxiety would eventually go down, right? So that's the whole point of exposures, that if you actually stay in a situation, your body can only be at that high level of arousal. Humans that's the beautiful thing about doing exposures and why I love doing exposures. And because, that fight or flight mode we talked about when you're running away from the lion, your body's only wired to stay at that high level of arousal where your heart's beating fast and you can't breathe for a certain amount of time. Even though you think you might stay at that high level of arousal forever, your body will eventually not stay at that high level of arousal. You will eventually start to feel better. But if you don't stay in the situation, you'll never get to realize that your anxiety will eventually go down anyway. You think the only reason your anxiety went down is because you left the situation, or you crossed the street, or you left the social situation at the party, right? So you never actually get to see that your anxiety is going to go down most likely anyway, or that you can live through the situation, that whatever happens, you can cope with it, right? So that's the whole point of exposure, is learning that you can actually cope with the anxiety-provoking situation versus running away from it. And that eventually, your anxiety will most likely go down anyway. Not always. Some people don't necessarily habituate to the same extent that others do, but eventually, nothing bad is going to happen to you in that situation. You learn that your feared consequences don't come true, right? So that is the beauty of exposure. And like we said, we don't tend to throw you in the deep end all at once. It's called graduated because we start out with easier situations, and we gradually work our way up to harder situations. We call that a fear ladder, or the official name for it is a fear hierarchy. But you progress your way up the fear hierarchy from less anxiety-provoking situations to progressively more and more anxiety-provoking situations. So the fear hierarchy's official name for it, we can also call it a fear ladder, or a fear staircase, or a fear elevator, or a fear mountain, whatever you want. Just the general kind of metaphor of working your way up something is helpful for kids. This is an example fear hierarchy for one of my girls with autism, actually, and who was afraid of thunder and lightning. And you could see we had her rate her anxiety from not afraid to very afraid. And, we confronted these situations from easier to harder, where we start out with just looking at pictures of thunder and lightning and working our way up to listening to thunder and lightning and watching videos of thunder and lightning and seeing something that looks like lightning. And, eventually we were able to work our way up to watching and listening to thunder through the window when we're inside, watching the lightning outside and listening to thunder outside while having our hands in her ears, and eventually watching the lightning outside and listening to the thunder outside while having her hands out of her ears. We try to limit those avoidance behaviors, such as putting your hands in your ears, because if you're doing that, then the individual thinks the only reason they made it through the situation is because they had this avoidance behavior, or safety signals we call it sometimes. So the only reason I made it through was because I had my hands in my ears, or the only reason I made it through this panic attack is because I was holding my special panic pillow, or whatever it happens to be. You don't want people to, again, rely on those sort of crutches. You want people to realize that whatever happens, you're going to make it through the situation that makes you anxious, okay? So we're able to work our way up from these situations to the situations that made her very afraid. And she was able to conquer her fear of thunder and lightning, which was wonderful. So that's really the key ingredient of most exposure, of most treatment for anxiety, is exposure, graduated exposure, okay? And it's very, very hard to really, some would say impossible, to treat anxiety without exposing yourself to it in some way. Okay, which is, the part that no one really wants to hear, but that's the reality. All right, and then the other main component of anxiety is what we call cognitive restructuring, and that's challenging your anxious thoughts. So first you have to identify when you're having anxious thoughts, and then really challenging them. So for example, the girl who was afraid that, she was going to wind up becoming a stripper if she failed a test. Do I know for certain that's going to happen? Do I have a crystal ball? And what evidence do I have that that's going to happen? Or what evidence do I even have that I'll fail this test? Have I ever failed a test before? Or is there another explanation for that? So for the individual who's crossing the street and says hi to someone they know and the person doesn't say hi back to them and they think, oh, he hates me, he's mad at me. Is there any other explanation for why he didn't say hi to you? And that's when you help the individual generate other explanations, like, oh, maybe he didn't see me, or maybe he was running late for something, or, maybe he's not good at recognizing people, or maybe he's sort of in a fog or in a cloud when he's walking down the street. And when you can come up with other explanations for the situation, it can help you think differently about it. What's the worst thing that can happen? How bad is that? How can I cope with that? So for the girl who's afraid of the spider, for example, and thought, oh my God, the spider's going to crawl on me and bite me and I'll die. Thinking, how likely is it that the spider's going to crawl on me? Well, it's probably not going to crawl on me. Last time I saw it in the bath, it didn't crawl on me. And, even if it did crawl on me, what's the worst that can happen? I guess I'll just swat it. You know, that other time a spider crawled on me, I just swat it and it fell off me, right? So how bad is that? What if the worst does happen? What if I do fail the test, you know? Because you can say, you know, have I ever failed a test before? No, so most likely I'm probably not going to fail this test. But let's say even the worst happened and I did fail this test. How bad is that? How would I cope with that? What would happen then if the worst thing really did happen, you know? So that's a big part of cognitive restructuring, or challenging those anxious thoughts, fighting your anxious thoughts. And another piece of it is coping self-talk, which is related to that, you know, just because sometimes it's especially very difficult for kids, and especially kids on the spectrum, to really be able to challenge it. So it's a lot easier for them to just kind of say coping self-talk, like, I can do this, I've handled this before, I'll handle it again, my brain's just stuck right now, I don't have to do this. Sometimes in treating OCD, which is a form of anxiety, they use the term boss back talk, like bossing back your anxiety. So saying, stop it, leave me alone, OCD, you know, go away, you know, shoo fly. So really, you know, some of it is, again, just trying to, and part of this also can be externalizing it. Like we said, giving it a fear or name helps you fight it. So saying, you know, you're just junk mail, you're not real, stop bossing me around, anxiety or OCD. And this can help you feel, you know, empowered, the child feel empowered rather than scared or trapped, right? So that's, again, a very important piece. And you, as a parent, can, again, help your child do that. You know, when your kid is afraid of something, you don't want to just reassure them and say, oh, there's nothing to be afraid of. And you know, you don't want to, again, make it seem like, I'm going to make you do this, you know, thing that makes you anxious. You just want to be a coach to your child in terms of fighting his anxiety. So reminding your child, you know, it's OCD, or if you named the OCD like Voldemort, if you named the anxiety or the OCD Voldemort, for example, you know, it's just Voldemort making you do this. I know you don't want to be worrying about getting sick, right? So what do you want to do now? Let's just tell Voldemort to leave you alone so you can go do something else fun, right? So you're just, that's what you're trying to do, kind of be your kid's coach. Okay, so all of that's an example of boss back talk and all part of cognitive restructuring, okay? All right, and another key piece is reinforcement. So reinforcing brave behavior versus anxious behavior. So you don't expect perfection, you know, just reinforce partial success or attempts. You know, if a child's afraid of, I'll talk about one of my kids who's afraid of happy birthday. You know, it doesn't mean they have to go blow out the candles in the first try, even if they are staying in the same room as the cake, or even if they look at the cake, or for a kid who has social anxiety, they don't have to go give a speech, even if they can make a phone call, or even, you know, what are the baby steps they can do? Reinforce any baby steps or any approach behaviors or any brave behaviors. Reinforcing is not the same thing as bribing. You know, the example I always tell parents is if you go into a bank and your kid starts screaming and you say, if you stop screaming, I'll get you ice cream. That's a bribe, right? Because you're reinforcing the bad behavior, basically, after it's already happened. This is an example Carolyn Webster Stratton gives. Whereas reinforcement is proactive. If you go into the bank, before you go into the bank, you say to your child, you know, if you're quiet and stand next to me quietly in the bank, we can get ice cream when you leave, right? In that situation, your child's never escalated. And it's the same thing here. You're not bribing your child. You're just, you know, reinforcing your child. Would you go to work if you didn't get paid, right? You're trying to reinforce your child for doing something that's really hard for them. Arguably, there is nothing harder for any of us than facing a situation that makes you anxious, right? Nothing. I'm terrified of it. So really, you have to make sure that the reinforcement for doing so is really, really powerful. This is a key piece. Your child is not going to be motivated to do it if there's not something strongly reinforcing that they're going to be able to earn for facing their fears and confronting their fears, okay? And, you know, the rewards can be tangible rewards, things they earn or privileges, getting to do something really special. Or for a child with autism, it can be their perseverative interest, the thing they're really, really obsessed with, and we'll talk about that more later. Another thing we do is you can earn stickers towards something or points towards a reward, or brave bucks, or at NYU, they called it Brave Bucks or Courage Cash, for example. You can come up with clever names of it where you earn things for brave behavior. Okay, so now that's basically how you treat neurotypical children. Now in terms of treating anxiety for youth with autism spectrum disorder, what's different? So those components that I just went over are the same. You know, when you're treating anxiety in kids in the spectrum, you still need to have exposure, some form of psychoed if you can, some form of cognitive restructuring if the child is able to understand. But there's some differences. With individuals with ASD, you really need an increased structure and predictability in delivering the treatment components. Individuals with ASD tend to be more concrete, so you need to be as concrete as possible, maybe writing down exactly what the person needs to say or do, keeping lists. I'll show you, I think on the next slide or in 2 slides, you'll get to see lists of, you know, what is anxious and what is not an anxious behavior, what's an anxious thought and what's not an anxious thought, right? You have to make it as concrete as possible to explain these things to the individual with autism, and use as many visual teaching strategies, pictures, written lists, prompts, posters as possible, right? That's one big difference. You need a lot more of that when you're treating individuals on the spectrum. Another is really an increased focus on generalization. We all know that individuals with autism have a lot more difficulty generalizing things they learn in one setting to another setting. So we really need to increase that focus on generalization. The classic treatments for neurotypical children with anxiety disorders, such as coping CAT, don't tend to involve the parents too much. You do meet with the parents, but the parents are not present with the child every session. Whereas in the cognitive behavioral treatments for children with autism spectrum disorder, such as Facing Your Fears, the parents are there. The parents come for every single session, and they're learning what the children learn. You know, treatment's different. Some treatments, the parent's always present with the kids. You know, like if I work with a kid alone, almost always the parent's always there. So that they're learning how I help the child, coach the child through his fear of thunder and lightning, and then they can practice the same thing with the child at home. Or in some groups like Facing Your Fears, they might meet with the parent and child separately, but teaching them the exact same thing. So again, the parents know what to do. All right. So that's another big difference for kids on the spectrum. And then I would argue, and in another big difference, I don't have it here, but along with that first part about the use of concrete and visual teaching strategies, I would say that the cognitive component of CBT is often significantly modified or downplayed, or sometimes we really can't address the cognitive component at all for individuals on the spectrum, and we really have to rely on more of the behavioral components, like exposing themselves to the situation and reinforcing themselves for exposing themselves to difficult situations. But we may not be able to do that cognitive restructuring. It may be a lot more difficult for them to be able to identify and challenge their anxious thoughts or even use any coping self-talk. So sometimes we de-emphasize that part or substantially modify it or even leave it out entirely. But we try to get it however we can, and I'll tell you how we do that in a few slides. And then another main difference is incorporating the children's special interests. In general, you know, you want to incorporate any child's special interests, of course, anything that they really love. But those of you who have children with autism or who work with children with autism probably know that kids with autism tend to have what's called perseverative interests. We also refer to those as circumscribed interests or special interests, meaning a really, 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 really strong interest in one or more things. Super strong interest. It consumes them sometimes, and they want to do nothing else other than that. And that can be an obsession with Star Wars or an obsession with Potato Head. One of my kids was so obsessed with Potato Head. We'll tell you about that in a minute. But so you really want to try to incorporate those special interests into treatment in however you can. And I think that tends to be a difference from neurotypical kids. Neurotypical kids don't necessarily have, you know, they may love TV or love computer or love a specific TV show, but they don't necessarily have something they're so obsessed with and consumed with that all they want to do is watch that one Elmo video over and over and over again 50 times in a row, right? So even though that can be a challenge of working with kids with autism, when it comes to treating anxiety, to me that's almost an advantage in that they have something they love so much that it might be powerful enough to combat their anxiety or compete with their anxiety, okay? All right, so treating anxiety in ASD, the main strategies I use clinically and use in the research I'll talk about in a minute come from 3 fields. The first is cognitive behavioral therapy, which is what I talked to you about already. So we try to use the same CBT procedures that are used to reduce anxiety in neurotypical children, things like the graduated exposure, the cognitive restructuring, the psychoeducation. We try to use those procedures and adapt them whenever possible for kids on the spectrum. The second literature is applied behavior analysis. There have been some studies using applied behavior analysis to reduce what's called avoidant behavior or avoidant responding in kids with autism. And they use things like systematic desensitization, which is basically the same thing as graduated exposure or counter conditioning, which I'll talk about briefly soon. They of course use positive reinforcement for the children desensitizing themselves to these certain situations and modeling, demonstrating for the kid what you're about to do. So for example, the study by Openden and Kagel in 2004, they use systematic desensitization to treat fear or dislike, whatever you want to refer to it as at the time, of certain sensory stimuli, such as blenders or vacuums in 3 children with autism. So most of the ABA literature does use some form of exposure or systematic desensitization to reduce avoidant responding, but they don't necessarily call it anxiety, right? Because like we said, in ABA, the focus is on the overt behaviors, and there's not the tendency to use the term anxiety because we can't necessarily measure the cognitive or feelings component. And then the third main literature is positive behavior support, which I talked a lot about in my presentation in June, okay? And positive behavior support, we can use a lot of antecedent-based and replacement strategies, have been shown to be successful in reducing problem behavior in ASD and DD. In those studies, it doesn't necessarily say those children are anxious, because again, in ABA and PBS, it can be hard to document anxiety, but a lot of those same strategies would likely be effective in treating problem behaviors that's due to anxiety or in treating anxiety itself. So I'll explain what I mean by that. So quickly, first we'll talk about modifying the CBT components. So how would you modify cognitive restructuring for kids on the spectrum? Like I said before, you would either de-emphasize or modify it to meet the child's developmental level. In some cases, you might have to leave it out entirely. But we really what I try to do clinically, like I said, and in my research, is we try to convey the psychoeducation and the cognitive restructuring components of treatment using a lot of visual supports. Things like social stories. So I always write social stories for my kid in which I explain the psychoeducation, you know, of what we explain what anxiety is. We explain that anxiety has a purpose. We talk about them running from a lion. We have a lot of pictures in there to help make those points clear. A lot of lists with pictures. So you can see the list here, like, for example, brave behavior, things I can do when I'm anxious, and afraid behavior, things I can't do when I'm anxious. Without that visual support, it might be really hard for a kid to understand. But this was for my little boy I told you about before with autism and obsessive-compulsive disorder, OCD, who would ask his mom, you know, am I sick? Am I sick? Am I sick? Am I breathing right? Am I going to get sick? Am I healthy? Is there something wrong with my brain? Am I breathing fast, right? And it could be really hard for him to know when he was doing those anxious behaviors or not. So we made this list for him where we could see on one side it listed all the anxious behaviors, the things he shouldn't do that made his anxiety worse. And then all the other things that were not anxious behaviors, things that he could do, like tell myself, I can do this, my anxiety will pass. Or he could go play tech or go play a board game or read a book, all the non-anxious or brave behaviors he could do. Okay? So that's an example of using a visual aid or visual support. Role-playing could be, you know, making it as concrete as possible, basically, to try to teach the child. So for a child who was afraid when his parents left the house, really, we role-played, you know, his parents leaving and pretended to be him and what would happen and how he would keep playing instead of running out after his parents, etc. These 3 pages I have on the bottom of the screen are 3 pages from one of my social stories that I wrote for the same child that I was just talking about, who was afraid of being sick all the time, afraid that he was sick. So as you can see, these 3 pages of the social story say, so to fight my anxiety, I will try not to ask mom these questions. And I think it's, I can't really say what it says in the thought bubble, in the word bubble, but I think it says, am I sick, or am I healthy, or am I going to get sick, or something like that. And to help me fight my anxiety, mom will try not to answer my questions by saying, yes, you're healthy, or no, you're not going to get sick, right? That was the reassurance piece. Then just like we have to eliminate avoidance or any safety signals, we have to eliminate the parent's reassurance a lot, because then the kid thinks the only reason they can make it through the situation is because their parents are reassuring them. So we have to show your child you can make it through that anxiety-provoking moment even when your parents aren't reassuring you, right? So, and to help me fight my anxiety, Mom will try not to answer my questions. Instead, Mom will say, that's just your anxiety talking. I can't tell you if you're going to get sick, right? So, again, this visual, really concrete strategy really can help kids. When I read the child the story for the first time, it was like a little light bulb went off in his head. He said, that's crossed out. That bubble's crossed out. I said, yes. He said, how come? I said, because that makes your anxieties stronger. And he said, it's crossed out. That means I can't say it? I said, you're right. That means I can't say it. He said, okay. It was amazing. He really didn't say it again, even without any reinforcement. It was like he just needed to be told that he wasn't supposed to say that, and that really helped him, which is amazing. So usually it's not that easy, honestly, but in that situation it was really, really helpful. Like seeing the bubble crossed out was like a light bulb moment for him. And then you could see in the third page of that social story there, it explains habituation. It explains how his anxiety will eventually get better when he stays in the feared situation. So at first when Mom says, I don't know, or I can't tell you, I'll feel scared. But after a while, I will feel less scared. Then after a while longer, I won't feel scared anymore. I will see that my anxiety goes down after a while, even if Mom doesn't answer me, right? Just like if you're petting a dog and you stay in this situation, you'll see that your anxiety goes down, even if you don't run out of the room with the dog. So I'll write these individualized stories for every child with autism I work with, in which we explain their specific feared situations and how to confront it. So that's how we modify the cognitive restructuring component. In terms of modifying the graduated exposure component, what I do tends to be more, like we said, incorporating their perseverative interests as much as possible. So, for example, one of my friends, Dr. Ali Matu, a wonderful clinical psychologist who specializes in treating anxiety at Columbia, he's really creative at doing this kind of stuff. One of his children with autism spectrum disorder who had a needle phobia but was obsessed with Legos, had a perseverative interest in Legos, he was actually able to create a Lego needle. Right, so that's a way of making the thing they're afraid of a lot less scary when you're able to incorporate their perseverative interest into it in some way. Similarly, and you'll see a lot of examples of that in a few slides with my 3 kids, who I'm going to talk about. Another thing we do that I tend to do often is called counter conditioning. Or sometimes that's referred to as systematic desensitization. So it's different than straight graduated exposure, in that in graduated exposure, you're just exposing the child to the situation without anything else. So if I was afraid of dogs, I would just be sitting in the room with a dog or looking at a picture of a dog or watching a video of a dog, whatever that step of the exposure hierarchy is. But for a kid with autism, especially one who is maybe nonverbal or it would be difficult to explain to them that their anxiety will habituate if they just stay in the situation, it might be necessary to actually pair that anxiety-provoking situation with something very, very highly positive, their perseverative interest. And the first time I ever did this was a child who was so afraid of going to the doctor that it took 6 nurses and the doctor to hold him down each time he went. And his most perseverative interest, the thing he loved the absolute most, was Potato Head. So much to the point where parents hadn't let him have it in a few years, I think, because he was so obsessed with it, it really consumed him. So what we did was we brought Potato Head back, but Potato Head lived at the doctor's office. So the only time he ever saw Potato Head was when he went to the doctor's office. So pairing the doctor's office with Potato Head helped counteract or compete with his anxiety. So when he first got there, the very first time we told him, as soon as you get there, you're going to get Potato Head, he just sat on the examining table playing with Potato Head. We didn't do anything to him. Then the very next time, and he was so excited to see Potato Head, he was like, the eyes, the ears, the nose, the mouth, he was thrilled. And then the next time he went, he was even able to let him look in his ears while holding Potato Head. And then the next time he went, he was even able to get a shot or blood test, I forget which, while holding Potato Head. So that's a big difference, is that individuals, with neurotypical children or adults, we tend not to like to do counter conditioning because we don't want them to think that, again, the individual, that the only reason they're making it through the situation is because they have Potato Head or because they have this thing. So we try to avoid that when we can. But for some individuals on the spectrum, like we said, who may have such severe self-injury or challenging behavior and not be able to understand that why they would need to confront the situation, it may become really necessary to pair it. In my clinical opinion, at least. Others would disagree with me on that, perhaps, and there's a lack of research on this. But it may be really necessary to pair it with highly positive stimuli. Another thing we tend to do is incorporate video modeling or video priming, and I'll talk to you about that with one of my specific examples in one or two slides. And we may need the parent to really implement positive reinforcement with a reward chart. Whereas, in classic CBT, the kid is kind of administering his own rewards maybe when he confronts a situation. The parent probably needs to take a more active role. And you might want to incorporate functional communication training, which I'll talk about in two more slides, in this slide actually. So this is just sort of, so we already talked about how we would incorporate CBT. In terms of incorporating positive behavior support, those of you who remember my June presentation, like we said, in ABA or in positive behavior support, classically it's viewed that there's four main functions to problem behaviors, such as self-injury, aggression, tantrums. One of them is to escape a demand, escape something you don't want to do, like escape doing homework or escape making your bed, or escape or avoid making your bed. Another main function is to gain attention. Another is to obtain a tangible item or activity, such as a food or a toy or an activity like computer. And another is sensory seeking, to obtain sensory stimulation or to escape sensory stimulation, basically, an automatic function. So that's the traditional kind of ABA view. The way I like to reconceptualize it is that problem behavior could also serve one of those four main functions, but the purpose could be to reduce anxiety in some way. Not always, of course. Sometimes it is just to gain attention or escape something you don't want to do. But sometimes individuals with autism may resort to self-injury or aggression or tantrums or what have you to escape not just a situation they don't want to do, like homework as in noncompliance, but escape something that actually really makes them anxious, or like the doctor's office or singing happy birthday, whatever it happens to be. And maybe it's not just about gaining attention from mom and dad, but maybe it could be about gaining comfort or reassurance, like the little boy who would ask his mom, am I sick, am I sick, am I sick all the time? And if she wouldn't answer, it might escalate to problem behavior. Instead of just to obtain a preferred tangible item or activity, it could be to obtain comforting or self-soothing object or activity to reduce your anxiety. And instead of just obtaining sensory stimulation or escaping sensory stimulation, it could really, one of the functions could be to reduce feelings of arousal that are associated with anxiety. So any of those four main functions of behavior could be reconceptualized as reducing anxiety in some way for specifics, for a certain child, okay? And so to kind of revisit what we talked about in the June webinar about functional communication training, one of the main strategies you use for positive behavior support is once you determine what the function of behavior is, you teach the child an appropriate form of communication to replace that problem behavior. So if a child is yelling or screaming or hitting to get out of doing his homework, you might teach him to ask for a break from his homework or ask for help from his homework. Or if a child is making animal noises in class to get attention from his teacher, you might teach the child to say, am I doing good work, instead, to get attention from his teacher. So once you teach the child an appropriate form of communication, it reduces his need to engage in problem behavior to get his needs met, okay? So extending that to anxiety, if a child is trying to escape a situation that makes him anxious, you could also teach him to ask for a break or ask for help or ask for change in activity. You could also teach him to, again, ask for social interaction or attention or praise or reassurance, or ask for a comfort object or activity. So again, you could, teach an appropriate form of communication that helps him to reduce his anxiety rather than resorting to problem behavior. The one caveat I'm going to give, I don't usually use this, I use functional communication as a first-line treatment when treating problem behavior that functions to escape a demand or gain attention or gain a tangible or gain or escape sensory stimulation. I may not always use FCT as a first-line treatment for problem behavior that functions to escape or reduce anxiety. And the reason for that is because, again, we want the individual to be exposed to a situation that makes him anxious. We don't necessarily want him to be asking for a break or asking for reassurance. That said, with some children with autism, especially those, and again, this is all clinical. There is no research on what I'm saying right now on this slide. There really should be, and hopefully we'll do that at some point. But clinically, with children with autism, especially those with intellectual disability who've had a very, very severe aggression or self-injury, it's very difficult to just throw them into a situation that makes them anxious without giving them some kind of control over the situation. So, for example, for one boy who was with autism who was afraid of the sound of other children crying and would get very aggressive when other children in his class cried, we did teach him to ask for a break from, we would start out with practicing having him listening to videos or audios of other children crying, and we would allow him to ask for a break from that situation. However, we can't allow him to ask for breaks forever, right? Because then he'll never expose himself to the feared situation of other children crying and learn he could cope with it. So what we did was we gave him break cards in which he could ask for a break, and we gradually reduced the number of break cards over time so that he was increasingly exposed to the feared situation of other children crying, for example, okay? So FCT might be a strategy you would use, but you have to really kind of balance it with the need for graduated exposure. I hope that makes sense. All right. I don't have a lot of time to spend on these slides. These are the same, these next 2 or 3 slides are the same as the presentation I gave in June, I believe. These are just general positive behavior support prevention strategies, but they can be particularly useful in treating anxiety. One of them is just increasing predictability in general. We use visual schedules to do that, to really help a child know what to expect. And that is, that can be key in treating anxiety. Studies have shown with individuals with autism that there is less problem behavior in situations that are in which an upcoming event is signaled, aka predictable, versus unsignaled. So that just talks about problem behavior. They don't talk about anxiety, but if I had to guess, the reason for that would be because I would guess the reason for that is because there's less anxiety in the situations that are signaled when you know what to expect, when you know what's coming, versus those that in which you don't. So using visual schedules, and again, we want people to be exposed to situations that make them anxious. We don't want them to rely on crutches to get through. But something like a visual schedule is something we all use in life. I certainly know I depend on my Google Calendar. And so, certain things are maybe okay to really use if they're able to help the individual in some way and provide them with some sense of control over their environment. Another way to increase predictability is with timers or countdowns. Some children with autism, I've actually seen timers or countdowns make them more anxious, but other children it really seems to reduce anxiety for the same reason. I think I mentioned in my June talk, the subways in New York City now, they have a thing that tells you when the next train's coming. Like, next train will be here in 5 minutes, next train will be here in 3 minutes. And the reason for that is to reduce anxiety. We can't do anything about it. It's not helping the next train come any sooner, but it does comfort you or make you feel better in some way when you know when the next train is going to come. And it's the same for our kids. So again, to a certain extent, we have to learn to cope with our anxiety, but there's not necessarily a reason that you couldn't use timers to let people know how long they have to be in a certain anxiety-provoking situation, okay? This is one of those kind of coping things that may be okay. And again, it depends on the child. If a child is really relying on this as a crutch and is obsessed with how much time do I have, how much time do I have, how much time do I have, then it might be better not to use a timer. So, we have to really individualize this for every kid. Another way to increase predictability is using priming, where you preview future events under relaxed conditions on a one-on-one basis so that they become more predictable. Wild, Kegel, and Kegel, what they did was for a child, for example, who was overwhelmed by group instruction the next day when they read a story during story time, what they did is the parents would read the story at home the night before under relaxed conditions, again, one-on-one, so that it was less overwhelming for the child the next day. Again, they didn't use the word anxiety in this study, but my guess would be that the reason this was effective was because it made the situation less anxiety-provoking for a child. Same thing with kids with autism. Laura Schreiman, they did a great study with video priming, where they carried a camera through the transition setting to show the environment as the child would see it when progressing, like moving through one store, entering another store. And again, they didn't say the word anxiety, but my guess would be the reason it might reduce problem behavior is because it's reducing the child's anxiety associated with those transitions. Those of you who have a child with autism or work with them clinically know that they often have a lot of anxiety when it comes time to transition from one classroom to another, or from home to school, or from one store to another in the mall, right? So what we use that kind of strategy clinically a lot. Videotaping like a bird's eye view of what it looks like moving from one class to another, so that the child can watch it and become more familiar with it. And again, this might not teach the child to cope in the long term with transitions. Other strategies like exposures and cognitive restructuring need to be used, but it can certainly help reduce the aversiveness of the situation, so that it's a little bit easier for the child, especially in those early stages. Okay. Oops, sorry, I'm going backwards. Providing choices is another way to give children or adults, anyone, an increased sense of control over that situation. Because again, often when we're anxious, we feel trapped. We feel we have no control over the situation. So any control you can give the individual. Do you want to sit here or here when you see the dog? Do you want to do this or this? Any kind of choices you can give the individual really help increase their sense of control over the situation. Okay? All right, so that's the kind of background on how to treat anxiety in neurotypical kids, how to modify it for kids on the spectrum. And now I'm going to briefly try to take you through those the 3 children I mentioned that we operationally defined anxiety for, and showed that anxiety was higher and the problem behavior was higher in the high anxiety than the low anxiety situation. I'm going to take you through the intervention we did for each of those 3 children, or maybe only 1 or 2, depending on our time. So these are not their real names. The first child we'll call John. He was 6 years old at the time, and his anxiety context was participating in group activities, especially when people would sing happy birthday, which was very, very difficult for the family. Apparently there were a lot of birthdays in their family and with friends, and a lot of birthdays in the classroom, and this child would really run out of the room and cry and scream or hide under a table, and really it was very, very difficult for this child. Probably due to some combination of the group and the singing, as well as I think the fire from the candles was also a piece of it too. The whole thing was just sensory overwhelming for him, and really definitely made him anxious. So, and then the second child, Ben, his anxiety context was fear of being left alone at home, fear of his parents leaving. So when his parents would leave the house and run an errand or go somewhere and leave him with his uncle or grandparents or a babysitter, that was hugely anxiety-provoking for him. And his anxious behaviors were things like, Mommy, where are you going? Mommy, where are you going? Running to the door, looking out the door. John's anxious behaviors were things like cowering, freezing, running under the table, saying, here we go, everybody. A few things like that. I'm not remembering them all. And then Sam, his anxiety context was when his parents made left or right turns while riding in the car. So he would cry, go straight, go straight, go straight. He would start plugging his ears because he didn't want to hear the blinker that signaled that they were going to make a left or right turn. It wasn't just the blinker, though, because even if there was no blinker, he still would cry for left and right turns. But either the blinker was a piece of the anxiety, or at least just signaled that the left and right turn was coming. So that was his parents had really altered their driving route so they could drive straight as much as possible, which was amazing. You obviously couldn't drive straight forever, but they did drive straight more than you would ever imagine was possible. So those were the 3 children. So our multi-component intervention incorporated the prevention strategies we talked about, in which we alter the antecedent or setting events. For a refresher as to what those are, you could check out the June presentation I gave on positive behavior support. So the prevention strategies were really psychoeducation, which is also from CBT, increasing predictability, either using social stories or video modeling or video priming. Providing choices, or incorporating the child's perseverative interest into the activity, just like that example of the Lego needle. Using graduated exposure, but more than using graduated, so we were gradually exposing the children to the situations that made them anxious in increasing amounts. but also not just gradual exposure, but counter-conditioning, where we really paired the anxiety-provoking situation with their most highly perseverative interest. And then in terms of replacement strategies, you could use functional communication training or relaxation training, teaching relaxation skills. And clinically, I've used these with children, as I mentioned. But for these 3 children, we actually didn't use either FCT or relaxation training. We did teach the child, one of the children, coping self-talk. Ben, the child with separation anxiety with his parents, we taught him coping self-talk, which we'll talk about. But these are replacement strategies you could use. And then we use the consequence-based strategies of positively reinforcing them for brave behavior, for coping with their anxiety and for facing their fears. Extinction meaning not reinforcing their problem behavior or anxious behavior anymore. So, for example, not driving straight when he's screaming, drive straight, but making a left or right turn, right? And then differential reinforcement, which basically means you're paying a lot more attention to the brave behavior than you are to anxious behaviors, essentially, okay? So those are the main kind of strategies we used. That's the sort of multi-component intervention approach we take. Unfortunately, our video clips are not working with the webinar. I'm so sorry. But what I was going to show you was a baseline of John, which means pre-intervention of how afraid he was during Happy Birthday. He's running down the stairs here, and his parents are trying to kind of bring him back for Happy Birthday, but he's screaming and yelling, crying, and running down the stairs. Very, very afraid as soon as his family starts singing Happy Birthday. That's what you see in baseline. So the intervention for John, like we said, and these are the same elements, but I'm going to tell you how we individualize them for John. Oh, I'm actually not going to have time for all 3 children, I think, because it's already 2:15. Wow, I'm talking a lot, sorry. But the first component was increasing predictability, so making birthday parties more predictable. So we used video priming or video modeling, actually, for that. Video priming is when there's no model in the video, like we said, a bird's eye view of transitioning from one store to another. But for him, we actually used video modeling. He was obsessed with Elmo and Sesame Street, obsessed. That was his perseverative interest. So we had him watch a video of Elmo and Abby's birthday fun, which was not only very reinforcing for him, but really helped birthdays become more predictable and take on a kind of positive connotation. And we also increased predictability by using priming, in which we practiced or rehearsed or previewed the Happy Birthday with a pretend birthday cake, that toy birthday cake by Leapfrog over there. So again, it's kind of a way of practicing it. You could also think about it as a kind of low-level or easy exposure to Happy Birthday. You could think about both the video of Happy Birthday and the pretend birthday cake as very, very easy exposures also. So the next step, like we said, was gradually exposing him. So starting out with the birthday cake with the pretend birthday cake, starting out with a cake with the candles unlit, and gradually progressing to the candles lit. Starting out with just me or his mom singing to him, and gradually progressing to his brothers and dad, incorporating more people into it as well. Counter conditioning, so pairing, singing Happy Birthday with his most perseverative thing, which was, like I said, Sesame Street was his perseverative interest. So he was really obsessed with that Sesame Street pop-up toy pictured there, as well as that Sesame Street CD player. Those were his 2 most obsessive things, or perseverative interests. So what we did was we paired Happy Birthday with those. That's different than positive reinforcement, in that he didn't have to do anything to get them. Instead, we gave it to him non-contingently, which means that as soon as we entered the room with the birthday cake, singing Happy Birthday, we gave him those, either the Sesame Street pop-up toy or the Sesame Street CD player, okay? So he, again, the anxiety-provoking situation of Happy Birthday was then paired with Sesame Street, helping him to have a positive association with it, right, instead of a feared or negative association with it. We also used musical candles, and that he loved music, so that was kind of another kind of counter-conditioning strategy. Even though we initially gave him the Sesame Street toys non-contingently, we gradually transitioned to using the toys as positive reinforcement. So first, we just gave it to him as soon as we started singing Happy Birthday. He didn't have to do anything at all, like I said. But then after about 3 times of Happy Birthdays, 3 Happy Birthday sessions, we changed it so that he had to make some sort of approach behavior. So either sit near the cake, sit in a chair near the cake to receive the Sesame Street pop-up toy or then try to blow out the candle. And we don't care if he could actually blow out the candle or not. We were just trying to get him to approach the cake in some way. So if he made any attempt to walk up to the cake and blow, then we gave him Sesame Street pop-up toy. So again, we gradually transitioned from just pairing the happy birthday with the Sesame Street pop-up toy to positively reinforcing him for an attempt at approaching the cake with the Sesame Street pop-up toy. As I mentioned, we incorporated his perseverative interest, which was Sesame Street, both in terms of the counter conditioning, positive reinforcement, but also even in terms of increasing predictability with the Elmo's Birthday Fun CD. We also had him watch YouTube videos of Bert and Ernie singing Happy Birthday. And then finally, extinction, in that we prevented him from running out of the room, which is what he would have done before. We didn't hold him near the cake because that would have probably escalated his anxiety. Instead, we just, either closed the door to the room or maybe put chairs or something in the, if there was no doorway, just so that he wasn't able to run out of the room, but had to at least remain in the room while we sang Happy Birthday. Okay? All right, so that was Happy Birthday intervention. Unfortunately, we can't watch the intervention videos, like I said, because the video is not working. I'm sorry. I don't think I have time to talk about the second or third kid. I will just say, is there anything I should note about either of them? Oh, with Ben and his separation anxiety intervention, I will say that we did teach him coping self-talk, so he was obsessed with the characters Kylan. So in his social story, we had Kylan and his other perseverative characters saying to him, "I'm Super Ben, I can do it, I can fight my anxiety." So that helped him again to kind of cope with his anxiety. And the only thing I'll mention for the third child, Sam, who was afraid of left and right turns. So like I said, we had to alter the driving route so that parents were not driving straight as much as possible anymore. We worked our way up, the graduate exposures worked our way up from left and right turns that, first we were just listening to the blinker in the car, parked in the car in the driveway, for example. We started out with easier, quicker left or right turns and worked our way up to bigger left or right turns, like the intersection pictured there. The only thing I want to mention for Sam is the counter conditioning for him. I was particularly proud of what we did, and that his perseverative interest was Dr. Seuss. In particular, he loved the story The Sneetches, and so we made an audio recording of the Dr. Seuss stories. He liked The Sneetches best of all, so he would listen to that one. And he would get to listen to the Dr. Seuss recordings on his headphones while riding in the car. Again, in CBT, people would say that you shouldn't do that because that's distraction. So then the child's learning that the only way he can get through the situation is by being distracted from it. But again, I don't have data to back this part up. Clinically, he did not seem to be distracted. Each time he approached a left or right turn, he looked out the window and turned back to watch the left and right turn, which was one of his anxious behaviors, showing that he was aware of the left-right turn. It's just that I believe the Sneetches or the Dr. Seuss recordings competed with, were more powerful than the anxiety. Were so reinforcing that they were able to kind of counteract or overcome or overpower the anxiety in that instance. That is my hypothesis. We also incorporated his perseverative interest in Dr. Seuss into the social story, in that he was afraid of left and right turns, but loved the foot book. So we made a story of left foot, right foot, left turn, right turn, right, turns in the morning, turns at night. So in that way, we were able to incorporate his perseverative interest into many elements of treatment. And I will just say the frequency of all of their problem behavior dramatically decreased. The frequency of their anxious behavior also dramatically decreased from baseline to intervention. And the frequency and their blind undergraduate subjective ratings of their appearance of anxiety also dramatically decreased from baseline to intervention for all three children. I'm going to skip over limitations and future directions and just kind of say in summary, you can use all of these strategies from positive behavioral support to augment standard CBT. And I think that's basically it, that you do need to modify CBT in the way we talked about, but that is very, very possible to address anxiety in children with autism, regardless of their level of intellectual disability, using some of these cognitive behavioral ABA and PBS sorts of strategies. I think that's it, and I'll take, there's some books that I think are very helpful and some websites I think are helpful, and I'll take questions with our remaining 10 minutes or so.
Okay, great. Hey, Lauren, thanks so much. It's been really interesting, and we have a lot of questions, as you can imagine.
I'm sure. I'm sorry I talked so much there.
Oh, no, it's okay. I think one of the, I want to make sure some of our audience members have adults or older children with autism, and I know that your clinical expertise has been really focused on younger kids, but I wonder, do you know of any resources that would be helpful for them? I know that the behavioral theories are the same regardless, but some of the questions I've had are about things that only, maybe adult children would be thinking about, like death and these sorts of issues. Fears of
right.
Have you heard about any resources for that?
Yes. So I don't know resources per se, but the procedures you use are the same. So even when we have an adult with an anxiety disorder, let's say, who doesn't have autism, and I've treated a lot of adults with anxiety disorders as well, the procedures are the same. So for an adult, for example, and this is going to sound very morbid, I'm sorry, but who was very afraid of her child dying and would constantly be consumed by her child dying and had to engage in all these rituals like stacking up her newsletters in a certain way to prevent her child from dying, we actually did what's called imaginal exposures, where we had her imagine her child dying. I know this sounds horrible, and she would kind of recount. We had an audio tape or videotape you could do, a version of her talking about, her child dying, and then she falls out the window, and then and she would tell the same story over and over and over and over again, and we would record it each time and have her listen to it for homework too, and record it each time. And she would rate her anxiety on a scale of 0 to 10 or 0 to 100 each time. And what she saw over time is, again, you can, even though it's painful, and of course the thought of your child dying is always going to make you sad, and no one wants that, the more she was able to kind of listen to that recording. Because what happens is, just like if you say to someone, don't think about a yellow taxi, you're going to think about a yellow taxi. So what happens is anytime you're afraid of something, part of you is telling yourself, don't think about it, don't think about it, don't think about it. But that only kind of makes it come back stronger. So it actually makes you a lot less anxious if you're able to talk about it. And again, with each retelling of the story, she became less and less anxious each time. Her overall, what's called subjective units of distress, or SUDs, decreased each time she was able to tell that story. So basically, you can do exposures with almost anything. With things that are really hard to expose yourself to in real life, you can do imaginal exposures, where you kind of imagine the situation and verbally describe it and tell it over and over again, and or listen to it over and over again. I hope that answers your question.
Okay, great. Yeah, I think that really addresses several of the questions that we had. So thank you so much.
Great.
So some of the questions we've had are from people whose loved ones aren't necessarily diagnosed with autism, although several people said they suspect that diagnosis is coming. And they're asking if visual strategies would be effective even with somebody who doesn't have a diagnosis. So I think they're thinking if maybe their child has ADHD or ADD, if those...
Sure. Oh, absolutely. Yeah. Visual strategies, like we said, we all use visual strategies, right? Like just like the example I gave with the subway of seeing the 5 more minutes till the next train comes, that helps everyone. Or if you have an agenda book, or if you have Google Calendar, those are visual supports you're using. Or how many of us, I know I do, I put up Post-it notes reminding myself to do everything, right? Those are all visual strategies. So we all use those. We all use those. We all need those. We all benefit from those. It's just that kids with autism might need those even more than the average bear. But certainly anybody could benefit from the use of visual strategies or supports, sure.
Okay, so this person's actually asking about hypnotherapy. Have you seen anything like that used for anxiety effectively, or do you know anything about that topic?
Hypnotherapy?
Right, so I think they're talking about
I don't know anything about that. No. I'm a behavior therapist or a cognitive behavioral therapist, so I don't tend to know anything about that.
Okay.
I don't believe there's evidence for that, but there very well might be. I don't know. All of the evidence for treating anxiety in neurotypical kids all shows that basically the only thing that's effective is behavioral or cognitive behavioral therapy. There's much less research, like we said, on individuals with autism, but there have been several RCTs, randomized controlled trials, that have come out in the past few years by Jeffrey Wood's group, Judy Raven's group, Susan White, a few people who have shown that CBT modified in the ways I described with making it more concrete, increasing parental involvement, incorporating perceptive interests, etc. Modifying CBT in those ways is also shown to treat anxiety effectively in children with, quote, high-functioning autism spectrum disorder, those who have an average or higher IQ. There's very little research, almost none, I would say, in children who also have an intellectual disability, other than the study I just did, which I just described with those 3 children. And then there's some older ABA studies, like I said, that treat avoidance behavior, like the study I talked about, with systematic desensitization to treat the fear of vacuums and blenders. But I don't know. I don't know of any research on hypnotherapy or anything else.
Okay, here's a great question. It's about school. So in a school setting, it isn't always possible to do graduated exposure. What would be the best way to deal with it, especially in our nonverbal population? I'm thinking fire drills, tornado drills, going into large groups of assembly.
Yeah, and you still do have to do graduate exposures. There's different ways to do it, like we said, right? So fire drill, that's actually one of my common ones. A lot of my kids have. We make social stories about fire drills, and you can think of the lower steps of the exposure hierarchy or the fear ladder, right? We'll have kids listen to audio recordings of fire drills on their computer at home, videos of fire drills. Then we might have them do that in school, in their classroom, in a counselor's office. And you might actually work your way up to the point where, often the principal will agree to have them come in like before or after school hours and play the fire drill over and over again as the final kind of step in an exposure hierarchy. But you can definitely do those things and should and need to do exposures in school settings, absolutely. Again, it doesn't mean you're doing that final level of it, that you're playing a fire drill all day long, because think about it, there's lots of practice things you can do, again, to work your way up to that. You're not starting out at the level of fire drill anyway. But often teachers or principals will be accommodating in helping you do those final kind of level exposures, such as playing the fire drill. Such as, actually, I don't know if playing is the right word, but setting off the fire alarm, you know what I mean? Does that answer your question?
Yep, I think so. And I think you covered that well in the talk as well. So
good.
Be a place for measured breathing or meditation in treating anxiety in children with ASD, looking for ways to help a child achieve calm in instances where anxiety is triggered.
Good. That's a good question. June Groden has done a lot of great work on modifying, and I didn't talk about relaxation training today, and that's because I actually didn't use it with those 3 children in the study, and a lot of the time I don't use it clinically because some of my kids do have trouble understanding it, and sometimes it'll make them more nervous. They'll say, am I breathing right? Am I breathing? Am I doing it right? And sometimes it could kind of escalate their anxiety, but I know June Groden's done a lot of great work on at the Groden Center on using relaxation, like deep breathing, progressive muscle relaxation to reduce anxiety. And that is something I'll usually put in my social story, say, when I'm anxious, and list all the things they can do. Like, I can go watch a movie. I can go play with my tech deck. I can do deep breathing like this. It's one of the many tools you can teach a kid to use when they're feeling anxious. But the main thing you really do want kids to rely on, if they're able, is, you don't want them to think, that, again, that they need to, because the crutch a lot of kids fall into is, I need to breathe a certain way to make my anxiety better. And what you want kids or adults to realize is that whatever you do or don't do, your anxiety is eventually going to go down in that situation. You will be able to cope with an anxiety-provoking situation, whether you breathe deeply or don't breathe deeply, right? But certainly for kids who have trouble understanding that concept, teaching them to breathe deeply can be helpful. And you can do that in many ways, like teaching them to take 3 deep breaths. You can say, pretend you're blowing out a candle and hold up 3 fingers and blow the first finger, the second finger, and blow out the third candle, right? Because you're trying to teach them to breathe in through their nose very slowly and breathe out through their mouth. You can have them do it like they're blowing bubbles, too. That's another good way to kind of teach that deep, slow breathing, blowing feathers. I'm trying to think what else. In terms of the progressive muscle relaxation, relaxing all their muscle groups, Donna Pincus has made a great CD called I Can Relax that I think is on childanxiety.net. But I've made my own recordings for kids of doing, tensing and loosening their hands and all their different muscles to try to help them relax. And you can also buy a relaxation book by June Groden that has a lot of visual drawings to help you help kids relax. Okay.
Okay, great. Well, I think we only have time for one more question. I think the last question we'll ask is, If a family wants to seek some support, some clinical support for this, how do you find a therapist or a psychologist who is your approach?
That's a great question. Hopefully those websites should be able to help. The Anxiety Disorders Association of America, the Association of Behavioral and Cognitive Therapies, abc.org, has a Find a Therapist link too. I think you know, different cities have clinics. Like there's a wonderful anxiety clinic at Temple University, Phil Kendall's clinic, where they have the coping cat treatment, which was probably one of the first. Judy Raven's clinic is at the University of Colorado, and they specifically work with kids with autism. If you contact me specifically, if you live in a specific place, I might be able to direct you towards a resource. But probably these websites have some great resources. But in general, you could also just call providers that are in your insurance and ask them if they have experience with cognitive behavioral therapy. A lot of them, you know, it is kind of rare sometimes to find either CBT therapists who are specialized in treating autism, kids with autism, and not just anxiety disorders. And then it can also be difficult to find ABA practitioners for kids with autism who are specialized in treating anxiety. That can be difficult to find those two things. But I think hopefully, if you know, that's why if you know these things, you're able to help yourself too. Like the girl I was telling you about who was afraid of thunder and lightning. Her first therapist she saw before she came to me had her listen to headphones whenever there was thunder and lightning, which hopefully you guys realize from this talk is not the approach you want to use, right? Because then you're just teaching the child that they can't cope with anxiety. You're teaching the child to avoid the thunder and lightning rather than they can cope with it. It can be okay to have them listen to a headphone with music playing at the beginning, as long as you gradually decrease that volume over time so that they realize that eventually they have to hear the thunder and lightning. So sometimes when you see a therapist who isn't trained in CBT, they might not know that you have to expose yourself to the anxiety-provoking situation. So that can be an issue. But again, these are questions you can ask a provider when you call up if they're trained in CBT. And again, if you see things like that, if you see a therapist kind of encouraging avoidance behavior, you know, that might be a good kind of cue to maybe find someone different.